I thank you. Apologize for my bad behavior. John McCarthy.
Chairman Baucus and members of the committee, thank you for the invitation to discuss Ohio's ongoing effort to create and implement an integrated care delivery system for Medicare and Medicaid enrollees. My name is John McCarthy, and I oversee the Office of Medical Assistance as Medicaid Director for the state of Ohio, an office within the Ohio Department of Job and Family Services. OMA is currently in the process of becoming our state's first cabinet-level Medicaid agency, a move aimed at bringing comprehensive reform and quality improvement to Ohio's healthcare landscape. Better care planning and coordination for Medicaid's dual-eligible population is essential to this work. Approximately 182,000 Ohioans are covered by both Medicare and Medicaid. However, the absence of any significant degree of coordination in the delivery of benefits between the two programs has contributed to a diminished quality of care. Frankly, the current system is confusing and difficult to navigate, and no single entity is accountable for the whole person. Additionally, despite substantial investments, Ohio's long-term care services and supports remain in the third quartile of states, and such spending will prove unsustainable with the rapid aging of Ohio's population. This has led to the fact that individuals enrolled in both programs make up 14% of Ohio's Medicaid enrollment, but they account for 34% of all expenditures. Clearly a hotspot in the discussion involving care quality and cost containment. The time has come to improve coverage for individuals enrolled in both Medicare and Medicaid. In its efforts, Ohio is hoping to achieve the following: one central point of contact for enrollees, person-centered care that is maintained seamlessly across services and settings of care, a system that is easy to navigate for both enrollees and providers. Of course, in order for any initiative of this kind to prove effective, it must place the individual first. That is why we have made every effort to emphasize the need for real person-centered care that moves seamlessly across services and care settings alike. A series of enrollee protections have also been included to ensure that high standards for care are maintained on a consistent basis. With at least 2 plans in all regions, beneficiaries will have the ability to have the power to choose what avenue of care best fits their needs. Eligible individuals also reserve the ability to opt out of the Medicare portion of the initiative if they so choose. ICDS plan member advisory groups will also be established, and a unified grievance and appeal process will be implemented in order to further assure individuals that their needs and concerns are being heard. Finally, strong safeguards will be put into action to ensure quality management and proper oversight over all aspects of this initiative. However, the #1 protection for individuals in the program is that they are guaranteed continuity of care for 1 year with all providers, except for assisted living and nursing facility providers, where they are guaranteed 3 years. Providers have also been protected from rate reductions from the Medicaid rates for those same periods. The power of choice for beneficiaries is a common theme throughout the proposal, and that is no different in the enrollment stage. Individuals will have opportunities to make choices during the process, such as consulting over the phone with an enrollment contractor during regional education enrollment forums, or through one-on-one in-person enrollment counseling. It is important to note that Ohio is engaged with stakeholders and advocates throughout the design and development phases in this demonstration project. In order to ensure success and maintain a truly collaborative process, we will continue to reach out to providers, advocates, and individuals throughout the implementation and operational phases of this project. Thank you again.
Thank you very much, all of you, and for being here and for the work that you do on the real front lines called the rest of America.
First of all, Ms. McCarthy, where do you live?
I live in Dublin, Ohio.
Okay. Are there any Ohio State fans around there?
I am surrounded by
Do they have any idea you're from Indiana? Undergraduate and graduate school?
Yes, they know that, and I have had numerous discussions with the governor about that. Seeing that the state of Indiana has 3 #1 college teams as of today.
Oh, that's great. All right. I would get into why Montana. We're AA, 1AA in Delaware, and we lose to teams like Eastern Washington University, which I never heard of until 2 years ago. And I know you're all this is a team that plays on a red football field, and they managed to win the national championship. I don't get it. They beat Montana, they beat us. It's not fair. We'll beat one green. Okay. Let me talk about first of all, thanks a lot for being here. Thank you for being some of the laboratories for democracy as an old Buckeye myself. And we're delighted that you're here. Greater care coordination and care managers or these patient navigators are important folks. as we know, in the patient-centered medical homes and accountable care organization. And let me just ask how you're working in your own states to integrate your innovative programs for duals with medical homes and with the accountable care organizations. Could y'all take a shot at that?
Sure. In Ohio, we're bringing up, we took the path of going down the road of patient-centered medical homes for individuals with severe and persistent mental illness first, because actually what we were concerned about as we were bringing up medical homes for people with chronic conditions, what we saw was individuals, practices were looking at how do they get the behavioral health providers into the acute care providers' offices to provide services. But as we know, looking through our data, that is not where a person with behavioral health issues goes for services. Because when you look at it, if a person has SPMI and a chronic condition, they're not getting the services. So what we did in Ohio was brought up behavioral health homes first, where the behavioral health providers are actually out front, and they're bringing the acute care providers into their offices. We've incorporated that model into our proposal that we've put forward, because we know many of the individuals that we're going to be serving, I know we've talked about the elderly, but many of them have behavioral health issues. Mm-hmm. And so that is an integral part of, of our project.
Okay, good. Please.
And certainly for Washington, our first model is absolutely predicated on the use of health homes, medical homes, and we have experience in some pilots that we've done over the last few years, both on the behavioral health side and on disabled, under 65 disabled, where we've had great successes using a health home model in terms of not only bending the cost curve, but I think interestingly enough, finding statistical significant differences in the mortality of the individuals that were served in those programs.
It's a must in Arizona as well. You know,
start that again.
It's a must in Arizona as well. We mandate it from our health plans in terms of the structure to work with not only a primary care physician, but also to be a critical tool in terms of providing information back to those providers, so that the managed care system is really doing the most in terms of leveraging care coordination and care management, particularly for the populations like the behavioral health, high-cost behavioral health population, as well as specifically the long-term care population. So it's a must in terms of our structure and our delivery system.
Okay, thanks. How do y'all plan to ensure that your demonstration programs will include the most high-risk and high-cost duals in your states? That's my first question. Second half of that, would it be beneficial to your respective programs to have the option of including coordinated care models such as the PACE programs for your duals?
Well, in Arizona, we leverage managed care, so we don't have the PACE model in Arizona. And just to give a comparison, I think the PACE numbers nationally are about 25,000 members. In Arizona, we've got 40,000 alone that are aligned in terms of getting both their Medicare and their Medicaid from their Medicaid plan. So just to give you some idea of the scope of that. And obviously, by having that alignment, the plans have all the data on who their high-cost members are. Because you have that information, you can see who's using the emergency department too much, you can see who has, and it was in my data in terms of where you can stem the readmissions in the hospital. So we all talked about fragmentation, and clearly by having that single point of accountability, you really then can leverage the managed care organization to drive better outcomes for the member.
All right.
And I think in Washington, when I talked about the PRISM system, that's a predictive model.
By the prison system?
PRISM system.
Okay.
Not prison. PRISM. The PRISM system. That's actually a tool, a predictive modeling tool that we've developed in Washington that will help us focus, and we actually will be managing those highest cost individuals, or those individuals that we're predicting will be 50% higher cost using this model, and we've used this model for a number of years in various settings, and that the care management strategy is predicated on identifying individuals, so absolutely they will be the highest cost, highest need individuals to be served in our program.
Okay, last word, Mr. McCarthy.
And in Ohio, we actually left the PACE program outside of our proposal, because as Senator Rockefeller has talked about, it gives a person, you can opt out of our duals proposal into the PACE program. And so it's another way to do an evaluation of what's going on. We have 2 PACE programs in Ohio currently, one in the Cleveland area and one in the Cincinnati area.
Okay, thanks. Mr. Chairman, this is great. This is great. Thanks. Thank you all.
A very good hearing, and thank all of you, so much. You've traveled distances, suffered inconvenience to get here, even temporarily no lights, but thank you very much for your participation. And thanks, Senators, too. About 4 minutes left on the vote. Hearing's adjourned. Thank you.
Thank you.